Hi, Kittist. Over to you.
Oh, yeah. And then just to make sure you have the slides. Right. Okay, perfect. So I wanted to welcome everyone to our second installment for the Guidelines International Network Multimorbidity Working Group and the World Health Organization and West African Institute for Applied Health Research. In our second webinar, where we're discussing the WHO Essential Medicines List, Guidelines in Multimorbidity Care from a Global Health Perspective. So very excited to have a continued discussion from last time. So if you want to move to the next slide. So what to expect for today? So we're going to essentially go over the impact of the essential medicines list and an update on our multimorbidity care in Africa, and really think about more broadly how we can improve our use of evidence to improve care overall, especially with a focus on multimorbidity and polypharmacy and how that impacts these communities and populations and how we can move forward in the future. And then just connect together overall. So as far as our agenda for today, we're going to start with what we're doing right now, which is a welcome and some opening remarks and a recap of our webinar from last time. And then we'll dive right into our keynote. We've got two keynotes, and then we'll go into our panel discussion. And then I'm hoping, like we had last time, we had some really great discussions, some really fruitful points from our participants in the webinar, and then we'll close today with some reflections and kind of our next steps. Now, as far as for the introduction for our speakers for today, we have some wonderful folks for you, which I'm very excited to say that our first up for today is Dr. Lorenzo is back. And so he's the WHO Secretariat for the Essential Medicines List as a scientist. And so we're excited to hear his perspective again. We had some great discussions last time, particularly around polypharmacy and multimorbidity. And so I'm really excited to continue that discussion. And so we'll be discussing that again. And then we've got some fantastic perspectives from, planned approaches in terms of discussions on NCDs, which we know is a major contributor for multimorbidity, a major perspective for these, with Dr. Gonsi Simogo, sorry. And so I'm really excited to hear some discussions and perspectives here. And so I think this is going to be absolutely wonderful. And then as far as our panel discussion, we've got some wonderful speakers with you as well. And here we've got some additions. We've got, in addition to our two keynote speakers, we've got some next, if you want to go to the next slide. Kittist, who was one of our panelists from our last presentation, is one from the World Health Organization, but has done so much work in terms of guideline development and in terms of the quality assurance and standards at the WHO, and will be one of our panelists in our discussions here. And then next up, we have Patrick, who we know well as far as our gin work, especially in Gin Africa, and he's a medical officer in Cameroon and also team lead at eBase Africa, and has a very high level role in not only in the board of trustees in Gin, but JBI, and does quite a bit of research as well. And then there's me. So I'm an assistant professor in the School of Nursing at UT Health, and do guideline development for PD multidisciplinary teams, and have done some work in sub-Saharan Africa for cancer care. And then we have Miriam, who is going to represent a lot of, the work through WAFERs, and is a research director for WAFERs and does a lot of work in the LMIC space, and has been instrumental in our work on the stakeholder mapping and in the PAM project for the scoping review and the consortium for multimorbidity. And then we have Dr. Opeyemi, who's kind of kicked us off for today. And she's also an expert in guideline development and implementation, particularly around musculoskeletal conditions and multimorbidity, obviously, in her role here. All right, and so let's kick it off.
Thank you so much, Crane, for that opening remarks and the introductions of our speakers today. Next, we're going to have Lorenzo, and whilst Lorenzo is trying to put up his presentation, I just want to say that for all the attendees, please feel free to put your questions in the chat box as we go along. We'll be picking up some of those things, and also feel free to introduce yourself, because we also want to make this a platform for which people can easily connect with each other and collaborate for future work and discussion. So yeah, over to you. Don't let the chat box be silent, and let's make it interactive. Let's know what you're thinking. And obviously, if questions are very, very related to some of the things that will be discussed within the keynote, we will take them later on after start. Is that okay? So thank you, Lorenzo, and over to you. Thank you.
Thanks. I hope that you can hear me well.
Yes.
So, over the next 10 minutes, I'll have the chance to speak about the implication for multimorbidity care in Africa. Thanks a lot again for your invite to be here with you to share some reflections over the trajectory that the essential medicines related to multimorbidity will be going, right? And I'll start just with reminding some of the conclusions that I had in my previous talk, right? Is just to refresh mind. One of the key points was that the essential medicines are a global concept, and I would say that in Africa, almost all countries have national EML, right? Even though this is not always like the going, let's say, to medicine that would be reimbursed, but this is clearly like a medicine that have some kind of priority at the healthcare system level. Also, like talk about like I talked about the EML as not a basic list. So the EML, since now like a decade, is including medicines that would not be considered like a basic, but would be considered also like is medicines that are like is could be used in the hospital health care as compared to the primary care level. The EML is not a tool that would be giving unrestricted support to polypharmacy, right? Is the concept is to filter down the number of options. And so also is interesting to see how then the EML would be supporting multimorbidity. I made a clear distinction between when we talk about chronic disease treatments, multimorbidity and polypharmacy, and around some kind of a negative spin that sometimes is placed on multimorbidity or like even more in polypharmacy. I did mention the fact that medicines, at least in the ML, are evaluated as a medicines for an indication and not like is we usually don't review applications in which the medicines are evaluated, in which we sum up the number of indications. And then I concluded and say that the problem of the price is not associated with the type of disease, is associated, sorry, with the type of disease, right? Is so cancer or a rare condition rather than multimorbidity. And now I'll go like with the new slide to help myself. So I'll consider the next route, like let's say the next 5 to 10 years, and clearly here we are like seeing like a growing cycle for medicines and indications in African countries. So like this is a series of data in which we can clearly like be assured about the fact that the number of medicines that would be used, prescribed in Africa is going to increase. So this is a reflection also of what we have in the EML. In the EML, usually we have a tendency to add new medicines and to not remove that many. So as you can see, the number of medicines is increasing over time, basically. But it's also like to say that in Africa, clearly we have now like there will be like a few billions that would be invested in in these medicines, likely the essential medicines, and maybe it's less than what we have in North America or in Europe, but it's still like we are talking still about billions, right? That would be invested on medicines, and so that it would be meaning like an increase in the number of defined daily dose, right? Is also the number of medicine that will be then taken every day, but also like the resources that would be invested. And where would be these like medicines in which area? There are like a number of areas. Oncology and obesity are like clearly dominating the others areas, but we have like an increase that would be also like in mental health, in all of the part related to the cardiovascular diseases, clearly like the autoimmune diseases that are important, and diabetes. So, and now like I'll come to the idea of multimorbidity, and the key question is, do we have any elements to think that multimorbidity in Africa would be anyhow different from what we see like multimorbidity in other parts of the world, right? Is this kind of a possible? So let me go and talk about the most prevalent disease combinations that we are facing, right? The most important, right? The most frequent is that hypertension and hyperlipidemia, and I think is affecting like 10 millions of adults globally. I think it would be like the most prevalent also in Africa, if it's not already the top one. Clearly, with aging, these will become more and more common. And then on these, then we go on a series of multimorbidities. So to the hypertension and hyperlipidemia, we add diabetes, right? That is highly prevalent triad, often associated with the metabolic syndrome. And then we start to go to the next level, in which we have, on top of the cardiovascular diseases and diabetes, we have arthritis, right? Arthritis, psoriasis, these autoimmune disease, right? And this is when also start to be the price to cover all the medicines that to be quite significant. And on these, we can extend it then to the level in which we have asthma and COPD, right? And this is usually when the patients are pretty unhappy about the quality of life, right? And the health care outcomes, as it is quite difficult to be treated. And then we can again, like on the two latest one that I'm seeing is when we have mental health conditions, right? And usually these are like depression and anxiety. So when you expand then the multimorbidity as at the next level, you should be thinking about mental health, right? And then the other is when you have something that is, is like chronic kidney disease, because that is when the severity on, let's say, the cardiovascular side becomes really, really important, right? And that is usually is somehow when also like we are approaching we are approaching an end stage of life, right? Let me just talk about for like a couple of minutes about then what it means from a medicine perspective, because it's usually we can have now like what we have in the multimorbidity box. Okay, and now like let's think is that is different from in Africa from other places in the world. I don't think, and now let's reason about in terms of medicines if we can see some different patterns. So if we start with hypertension and hyperlipidemia, we have the cluster with all the diuretics, right? The AC inhibitors, the beta blockers, the calcium blockers, and on these we add then clearly like for the hyperlipidemia, the statins. Is that different? I don't think so. So all these would be basically medicines that are available and would be highly used also in Africa. When we add the diabetes, then we have metformin, okay, that is fine. Then we have human insulin, and then is when we start to expand to the insulin analogs as something, right, in which kind of the market is growing and is clearly like growing in Africa. Then when we add to arthritis, with arthritis, we have a new component in the multimorbidity that fits in, which is clearly also the pain. And so we are like looking to these medicine like ibuprofen, naproxen to kind of reduce the pain, the inflammation. And then we go to the second level, methotrexate, the steroids, and the anti-TNF medicine like infliximab, adalimumab, and others. So here is when we start to have then the biologics with the anti-TNF. And that is clearly when Africa can, in terms of multimorbidity, can somehow like still differ from other countries because you would be basically most likely to offer to most patients these the biologics that would be the biosimilars, which will have the most convenient price for the patients. These are complex molecules in which somehow is also important to be or to have to pay some attention and to have quality assured biologics, right? So to keep the level of effectiveness pretty high. Okay, if you go again then to diabetes, arthritis, and asthma or COPD, what we have is we have a number of medicines, but again, like is the key element that is the difference is with the biologic is not the salbutamol or like budesonide plus formoterol would be super difficult to be kept in a system like the African country. It may be what is changing is the coverage, right? The number of patients that have access. Mental health, fluoxetine, amitriptyline. So I would say antidepressants with decades of use. And then we have when we go on chronic kidney disease, in which we have the epoetins and then GLP-1. And then on GLP-1, I'll make a few words on the GLP-1 because to get a sense of the importance of multimorbidity for GLP-1, potentially we did also like with the fluoxetines before, but for GLP-1 is when you see that the EML is listing these medicines with already like a recommendation for an indication that is multimorbidity. Basically, it's recommended for the treatment of type 2 diabetes in adults who has also concomitant cardiovascular kidney disease, not risk factor disease, and obesity. So you see that now we are in an era in which even the recommendation in DML basically are already incorporating from the beginning multimorbidity as a key factor. And the GLP-1 are not recommended right now in 2025 for the treatment of obesity alone. Are not recommended. What it means? It means that in those countries that have sufficient financial resources, clearly the use of the GLP-1 can be also extended in patients with obesity alone, right? But the primer or where to start is those patients that are likely to get the most benefit out of the treatments, meaning those that have a high risk of significant harms derived from the disease. And that would be the patients that have like the three conditions together: type 2 diabetes, obesity, and kidney or cardiovascular disease. So, and this is my last slide, specific points that I think are important to consider for a continent like Africa, which of course is not all equal, but is that multimorbidity is ubiquitous. So like is in a way that this is not going to be like an important factor to be considered in African countries. Multimorbidity is more evident in certain specialist area and particularly close, I would say, to cardiology. As usually, this is a type of medicines that can be provided at the ambulatory care level and can be treated also by GPs, right? So I think that it's important to consider that these can be like multimorbidity can be tackled in African country, right? I see where these multimorbidity can be expanded over the future is, and these are like also the articles that we have on the right side of the slide, is that there is a tendency to expand now multimorbidity outside also the cardiovascular area into a pathology, into dementia, right? Because that would be increase the number of patients that would be eligible for these medicines. That may be not yet what I would consider like super important in African countries. I would be sticking to the cardiology side. And potentially the most important bottom line of my presentation is that it would be important to identify those medicines that are clearly key medicines for multimorbidity, concentrating there the prescriptions, and not having many prescriptions by the medical doctors in which there are many medicines, each one with a few prescriptions, meaning that there is a need to concentrate on, even for multimorbidity, on a few medicines that can, where there can be like a very well identified to control the quality and to avoid shortages, increasing the volumes and potentially also then reducing the prices. And with that, I have done. Thanks a lot.
Thank you so much, Lorenzo. Really interesting. You were sharing with us about how general practitioners in Africa can begin to look into the area of treating multimorbidity. And I do agree with what you said about multimorbidity being ubiquitous. There's still a long way to go. And thank you for sharing some of those pharmacological approach based on the current EML that can be used in that setting. So we're going to move on. We're going to take questions later on, but I just want to check. I don't know if Dr. Gunsi is in yet.
Yes, I finally managed to join.
Ah, good. Okay. Good stuff. You've been cloned as me, and we can hear you very well. So if it's okay, I will just share your slides now, just to help. Is that okay? Or you're happy to share it by yourself?
No, you can share from your end.
Okay. All right. Fantastic.
Or maybe I can try to share, just that because of the challenges that I experienced, I'm not sure if, because I had to change the computer.
Oh, sorry about that. Don't worry. I'm just gonna share if it makes things easier. Just a minute. I do that. I think you can see your presentation.
Yes, I can see.
Okay.
Let me turn on the camera.
So, yeah.
Okay, good afternoon. So I can start.
Yes, please. Over to you. I'm just trying to.
All right, no, thank you. My name is Fonze. I'm a medical officer for NCDs based at WHO of Afro-Congo Brazzaville. So I'll take you quickly through my presentation. I'll be speaking about the current and planned approaches to NCDs multimorbidity in Africa. Next slide, please. So just wanted us to few slides just to just highlight why maybe NCDs are important and why we are where we are today. So I think we all know that NCDs are the leading causes of death worldwide, and cardiovascular diseases being the main causes of NCD deaths globally. Next slide, please. And like I was saying, 75% of all deaths in the world are from NCDs. Next slide. And when we go back to now the Africa region, it is estimated that NCDs were responsible for 35.4% of all deaths in Africa in 2021, and that was a rise from 24% in 2000. Next slide, please. And we all know that NCDs are preventable if we address the risk factors and then we maximize on early detection and management of major NCDs, then we'll be able to achieve. So just to remind ourselves that we have actually made some commitments. We have the SDG 3.4 that calls for a 1/3 relative reduction of premature mortality from NCDs by 2030. And if I recall very well, there is no African country that is reported to be on track to achieve this target. And we also have some UN political declarations on NCDs, the most recent one being in September 2025. And we also have other universal health political declaration, and all these things are just a great emphasis on NCD prevention and control through a primary health care approach. Next slide. Now I'm moving on to my assignment for today. So I'll be just quickly talking about the approaches that currently are being implemented to address NCDs multi-morbidity in Africa. So next slide. So there are quite several initiatives, but I chose just these few that I wanted to just highlight because we currently have ongoing like projects and also countries that are implementing. So, but the main strategy here is the Global Action Plan for the Prevention and Control of NCDs 2013 to 2030. Actually, it was up to 2020, but it has since been extended to 2030. And then we also have integrated people-centered health services. We have the WHO technical packages. We have the WHO PEN. We have PEN Plus. We have MH-GAP, and we also have the HARTS. I will explain them in my next slides. Next slide, please. And then these ones, I'll say they are planned approaches because currently they are being piloted in some countries. We have what is called the WICS, Women Integrated Cancer Services Initiative. I think maybe we can just proceed to the next slide. I'll cover this as we go along for the sake of time. So in terms of WHOPEN, its main purpose really is to provide a prioritized set of interventions. Prioritized, of course, effective interventions for NCDs targeting the primary health care level and especially in low resource settings. And it provides the framework for delivering essential interventions for NCD prevention and management at the primary care level. And it focuses mainly on the major NCDs, your usual cardiovascular diseases, cancers. For cancer, it actually has the element of cancer prevention. for breast and cervical cancer, and then your cardiovascular diseases and your chronic respiratory diseases. So next slide, please. And then we also have the PEN Plus. The PEN Plus is it's a regional strategy. This one is specific for the Afro region, and it just extends the WHO PEN by addressing severe NCDs, usually, for example, type 1 diabetes, sickle cell disease, rheumatic and congenital heart disease. And it provides decentralized outpatient services at first-level referral hospitals. And the main focus, it's actually focusing on children, adolescents, and young adults in rural and underserved areas. And it just complements, it just complements PEN, because PEN is like lower level facilities, and then for PEN Plus is like a district hospital or regional hospitals. So that's the difference between the two approaches, and the other one targets more complicated cases as well. Next slide. So, and then we also have the MH gap. MH gap mainly is for mental health. It's for mental health, and the reason why MH gap was it was mainly to drive the narrow treatment gap, because currently up to 75% of people in low middle income countries, they lack access to mental health services or mental health care. And it provides evidence-based guidelines for integration of mental health into primary care and non-specialist settings. So I think all these interventions, they are trying to strengthen, it's just basically health system strengthening, targeting the primary health care level. And most of them, actually, I didn't go back. I haven't, because of the time, I have not been focusing, like mainly all of them, they have one thing in common, actually. They talk about, they prioritize task shifting. Task shifting either from nurses doing some of the non-nursing duties, or nurses maybe, like even for some countries, like for PEN Plus, for instance, nurses are actually being trained to do the ultrasound. So they're doing some of the jobs maybe that were meant for or doctors or for clinical officers. So task shifting, I think, is the core of all of these technical packages, and they promote people-centered integrated care across the life stages. Next slide. HEARTS is, I would say, is just a component of WHO PEN, but this one mainly focuses on hypertension and cardiovascular disease management, and is part of the broader global health initiatives, such as the Shake for Salt Reduction and the Empower for Tobacco Control. And the HEARTS technical package has 6 modules. It covers your healthy lifestyle counseling. It has also the evidence-based treatment protocols, and these are just simplified algorithms for hypertension and cardiovascular disease management, just to simplify the management, because sometimes when we have like treatment guidelines most of the time are really not available, but this one is just like a one-page algorithms that you can post in your health facilities for easy access. And also it speaks to access to essential medicines and technologies. And like I talked about, also the risk assessment. So those are some of the modules that are covered under HEARTS technical package. Next slide. So this one, like it's actually the main, I think all these technical packages are actually derived from the global action plan, because it's just the strategic plan that is laying all the foundation. But I just wanted to talk about it here, because when you look at its scope, it has an element of health system strengthening, where it speaks to the integration of NCD services into primary health care and the universal health coverage benefit packages. and also highlights the importance of essential medicines, your diagnostics and your technologies that should be available at all levels of care. And just like all the other technical packages that I talk about, because like I'm saying, this is the core, this is where all other packages are coming from. So like your workforce training, your task shifting, and your protocols, all are guided by the Global Action Plan for NCDs. Next slide, please. I'm trying to go fast because I only have 10 minutes. So for this one, like I was saying at the beginning, that these are sort of like, I'll say the planned approaches, because currently they are still being piloted. Like if you talk about the WICS project, the Women Integrated Cancer Services Initiative, it's a project. It's currently, not a project. It's integration of breast cancer and cervical cancer, and also diabetes, screening for diabetes and hypertension, as well as mental health. And this is actually guided by is part of the initiatives that are under the Global Cervical Cancer Elimination Strategy. So the decision was just to use cervical cancer as the entry point. It's currently being implemented in 3 countries. I think it's Zimbabwe, Cote d'Ivoire, and Kenya. So with the hope that lessons learned, like the positive lessons learned that we'll get from this project, can be replicated in other African countries. And then we have what we called the Diabetes and Cardiovascular Initiative in Africa. And this is an initiative that actually just speaks to the integration of diabetes and cardiovascular diseases, mainly hypertension, because diabetes and cardiovascular diseases, they are more like twins. So if we have hypertension or we have high diabetes, the chances are that we'll have another one. So that's why this is the initiative that is currently being implemented in Ghana and Uganda. And then go back to the previous slide. And then we have also integration of NCDs into existing public health programs. This one is just a broader integration. We know that most of previously we're just used to vertical programming, especially when it comes to HIV. I think because of the limited, because of the global funding, because they have money from global fund, they had money from PEPFAR. So they were just doing their own like vertical programming. But currently the goal is to integrate NCDs into HIV, because when you look at HIV, the disease process, as well as the side effects of medication, they're actually risk factors for NCDs. And I know that initially people in the HIV space, they were not really keen on integration, because they always thought that will actually derail them from achieving their targets. But the studies that are coming up, actually, that is not the case. And also, even now, some countries, they are realizing that a lot of patients actually with HIV, they also have NCDs, especially cancers and hypertension. So that is where also now integration is very, very important. And also we know about the link between diabetes and TB. And then, but I think all in all, it's important that we have chronic care clinics where everyone with a chronic illness, they are actually attended maybe just at the same place, attended by the same clinician, instead of just one clinician saying, I'm going to be attending you for diabetes, and then you are going to go to the next room for hypertension. So this model currently, Uganda is implementing this chronic care clinics where all the chronic care patients are seen in outpatient, and they're attended by just the same clinicians. There's no way you say this clinician is for hypertension or this clinician is for HIV. So it's just a chronic care clinic, are seeing all patients with chronic diseases in one space. Next slide, please. I think this has already been covered, but I just wanted to highlight that the new inclusions that are relevant to multimorbidity when you specifically for NCDs, I've highlighted the GLP-1 because now you will have one medication that can actually manage a patient with diabetes, obesity, cardiovascular diseases, or chronic kidney diseases. And then you also have your fixed doses that these are just, they improve adherence. So I think those are some of the key things that I think in terms of multimorbidity, they are welcome development. But the main issue with some of this medication in terms of the African setting is the cost. Some of these medications are quite expensive. So there's need then to advocate for countries to actually include them in their national essential medicines list. But other countries, for instance, GLP-1, other countries already have GLP-1s in their essential medicines list, but it's indicated for diabetes only. So you cannot prescribe it for anything else other than diabetes. So it means there's just a lot of work that needs to be done to advocate so that they could expand the indication, especially for those that already have them in their EML. And then the fixed dose combination as well, I think is something that countries are, I think they're catching up. Some countries are catching up with the fixed doses. And I think we need to really advocate for countries to use this new WHO EML to revise their national EML, because I know that some countries actually take long to revise their EML. I know a country that I think they have since revised their EML like in 2016. So I think that we can use that as an advocacy tool to support countries or to encourage countries to update their EML. Next slide, please. Oh, okay, thank you. I think I've come to the end of my presentation. Thanks.
Fantastic. Thank you so much, Dr. Kansai. Really, really exciting. It's interesting to see what WHO, the approaches that you're using. And we've got quite a few questions in the chat box. But just before we go there, I'll just, I think all the panelists are here, and I just want to ask a few more questions before we begin to address the questions on in the chat box. Please, if it's okay, I want to ask Lorenzo. Now you've given us a really brief, good basis for the EML update and how it can be used. But the question really is that how can do you think these have been, what's the uptick in African countries, and what would you advocate to how EML can be better used to support multimorbidity care in Africa?
So what I would be worried is that there is a tendency by the prescribers really to expand the number of medicines that are used to an incredible level, in which you have somehow like a dispersion of the number of prescriptions all over, with and every single patient with exactly the same type of multimorbidity that we saw, taking a different combinations of medicines. So the one that we saw, but many others that would be added. That means clearly diverging from the EML, right, is at least the EML as recommended by WHO, like becoming a kind of an expansion to like an incredible level. That would be, I would say, the key risk. So from a system perspective, I think that the idea to having these say, highly frequent multimorbidity scenario that are going like to be kind of repeated and repeated. Most of the patients would be kind of getting one of these scenario, and then say like they should be receiving similar medicine, right? If there is somehow an harmonic prescribing around, there may be like some differences because there are several classes, right? And so within each class, a doctor may have a preference for a molecule, right? So there would be space for me too, but there will not be, it would be important to decrease the number of classes that would be used. That would be my one of the key area to defend in terms of implementing DML for multimorbidity in Africa. Basically, fighting back the expansion or the inflation of medicines in these multimorbidity cases.
Thanks, Lorenzo. Let me turn my attention to Dr. Okwen. What are your reactions to some of the themes that are coming up from the keynotes that we've heard today? And what is on ground? Because I know that you're doing a lot of work locally in Cameroon. So over to you.
Thanks very much, Yemi. And yes, I'm really happy to be part of this call today. And I've listened to the two presenters, and I think it's quite interesting, coming from a perspective of experience at the district health level, where actually all this it's like the playground for everything we are discussing. I think Lorenzo highlighted. He had one slide dedicated to the challenges in Africa, and Dr. Gonze also pulled on quite a number of slides with a number of projects that are looking at these perspectives, which gives us opportunity to start thinking about or start reflecting on the global interest that is on this in this space, and especially for the African context. So there are a number of things that I was also thinking about based on my experience. As we saw on the slides, GPs actually manage a lot of multimorbidity and comorbidity cases in low middle income countries context, and having guidance on how to manage the coexistence or the presence of two or more health conditions in one person at the same time is something that is very important that we begin to think about. Now, coming from the perspective of the essential medicines list, which, as I've always said, remains the best guidance for other diseases outside HIV, tuberculosis, malaria in Africa, we see that we need to be thinking as well from that perspective. How does the EML list help guide or help with in the space of multimorbidity? I'm trying to be careful not to say guide the practice of multimorbidity, because I think the objective of the EML was not to provide guidance, but that is the only thing that is close to a guidance. So the clinicians in the context have adapted to using it as their form of guidance, however limited it may be for guidance. So those are the thoughts that I have. But I think that more practically, what we can do as a network or as a collaboration or as a consortium will be to look at some of the projects that Dr. Gonse has presented and see what are the potentials of us really tapping into some of the lessons that they are learning in that space, or how can we contribute to lessons that are going to be learned in that space. So I think that is what I can give from my perspective. And I believe that, Yemi, you are also in a very good position within Gene Africa, within Gene comorbidity, within Gene multimorbidity, to be able to lead in this kind of space and then manage the different actors that you have been able to so well bring together today. Thank you, and over.
Yeah. Thank you so much, Okwen. And I think there is a common trend that is coming out here. The truth is, and I think Lorenzo did attest to that. It did acknowledge that currently the EML is not actually a clinical guideline. And what we do know is that based on the work that we've done as Gene Multimorbidity Group and WAFERs, Miriam could also speak to that a little bit, and probably Karen, we know that there is no clinical guideline to address multimorbidity care in Africa. There are a few, one or two in other low and middle income countries. And Dr. Gonse also mentioned about the forward thinking about integrating these things. Now, comorbidity, as we know, is quite different from multimorbidity, but although both of them sit really, really closely aligned. But what we need to be thinking, and she also talked about consistency on who sees a patient, about those chronic integrated clinics, where they see chronic care. Could we upgrade them? Could we look at them from the perspective of multiple long-term conditions and begin to really do some system capacity building to integrated care? Because one of the killing things, one of the major problems of addressing multimorbidity has always been siloed care. Because they go to HIV clinic one day, they go to diabetes and hypertension. Now, both of diabetes and hypertension is being currently recognized together. But still, people have more than that. People live with 2, 3. There is virtually, each time I speak to people, there is virtually no household where you don't have somebody over 50 that have arthritis pain, for instance. And with that, they've got either hypertension or high blood pressure. And like Dr. Gunn said, once you've got diabetes, you will have high blood pressure. It's a time-ticking bomb. So why are we not thinking of, an integrated setting that could address person-centered care? And I think that would be the way to move forward. And that could also be an opportunity to bring in the EML, which is really, quite carefully curated based on evidence. Although have it, a lot of evidence from high income countries, they've not been contextualized, but we can go on. I wanted to turn my attention to kiddies, Dr. Bartholomew. I don't know whether you want to say something about beyond the EML. The last webinar you did shared with us the WHO design principles. And one of the things I know, even though Patrick did say that EML is the main form of guidance for physicians, some physicians don't even know, some healthcare professionals don't even know about the EML. So are there any other products, or what can you advise going forward if we will be developing something or drawing up the key learnings?
Can you hear me?
Yes.
Yes. Okay, great. Sorry, I'm in transit between two places, so I don't have my camera on, but thank you so much. But I think just listening even the presentation today, everybody, if they can refer to the list of products from WHO that was mentioned, I'm talking the pen, the shake, and some of these technical packages and things, and for every different every health topic or disease or that you're talking about in this comorbidity, this is an important one. So the stuff I talked about last week is about these design principles, but because as WHO is moving into this discussion about talking about impact and pathway to impact and impact culture, one of the things we really looked at is it even our products, the way we put them up there, it's quality. The quality, the trustworthiness, nobody questions. This was from a qualitative study we've done a few years ago to look, and the trust in the product is never an issue. However, how they're packaged, how they are developed, how they are communicated or put out, as you've seen, leads to many challenges in countries, especially when they try to put them into practice. So what I talked about last week was the design principles, where we said, imagine if everybody kind of, as we're putting the teams together to develop these, starting from the evidence synthesis stage, if we really are really very much impact focused, basically designed by this impact by design is the project we were talking about is in. So we were looking at these 5 principles. I think we presented them last week, and they're really relevant. Basically, design with empathy, basically understanding the circumstances and the context these people are putting, implementing, especially in the African region, although things will change. So we have to be also forward looking, because we don't want to solve the problems of the past, but the future is digital technologies and wearables and things. So we have to think about, but when we designing this, how can we be very much interested in the users? So everything about the users, not even the topic. So that's design with empathy. Second one is design for living. Basically, the evidence changes all the time. So how can we design them in a way that as new evidence comes, that they are actually able to update quickly and not spend another 5-10 years or whatever to do it. And those changes are communicated so that countries can make their own decisions and where in they are in that. And then the third one is design with basically we cognitively translated into different languages and different health systems, different products. So how can we write them in a way that they are clarity and shorter, easy for translation. So third is again design for translation, the same thing. Even as we're moving into machines reading some of these things and put them how we do them, and we need to be really cognizant of these things even from. And the last one is design for accessibility. And I don't need to say much. I think a lot of people recognize this, and especially this network knows a lot more about the accessibility issues from different from different angles. So these are the 5. I'm happy to share more. These were out last January, December, was presented at the June, but since then it's been applied to a couple other products, which I will be able to share later for posting. Even have gotten some award and a design award because they speak to the current, and basically the future is more participatory and thinking about the emerging challenges, but also addressing those challenges. So I think I'll leave it there. Thank you so much.
Yeah, thanks, Katie. I think what you're saying is making me thinking about more public-facing document, more lay language documents that even healthcare professionals and healthcare workers who are at the very, very basic primary care level in rural areas can understand. Because I think some of the things that we're still talking about, I don't know, even with all the strategies that Dr. Gonzalez said, there is also the aspect of patient-facing evidence products for multimorbidity care. I've not come across anything in that space, especially that is contextualized and African-facing, to actually empower the patients to actually demand for care, so to speak, that is based on good evidence, supported by things like the EML and all these WHO PEN approaches. Good stuff. So I'm gonna just take a pause here. I've still got a list of questions, but I want to look at the questions in the chat box. I think Professor Adebajo has asked Lorenzo about the concern on the quality of generics and purported biosimilars. So how do you think the WHO can tackle drug quality issues for multiple long-term conditions or multimorbidity in Africa?
So thanks for the question. I would like to divide, the question on a 2 level. There is basically what is the WHO or the international levels that is pretty far from the frontline rheumatologist, right? So, what does WHO? WHO has, for instance, system to classify the regulatory agencies, their maturity, as far as the regulatory agencies from let's say, from smaller countries become more mature, more able then to check the quality of the medicine, right? They basically scale up the maturity level, and this is helping like the different countries from a system perspective. Is that really close to our colleagues that has to prescribe the biosimilars? Is not that close. So there should be also like a level that is mostly in the hands of the rheumatologists or the clinicians that is prescribing the medicines, also getting a sense about the quality of the biosimilar that are used and potentially shifting from one molecule or another. Some of the patients will respond even if the biosimilar is not the best quality, right? But there may be like a certain proportion, maybe 10 or 20%, that may be in need then to be prescribed and be switched and prescribed another molecule. If these 10, 20% becomes 80%, clearly there is a problem with the biosimilar that is used, right? So is that under the responsibility of WHO? Like how then can WHO, that I would say that is difficult, right? So there is a different level of different level of actions that may have implications that will need the time, particularly at WHO level, but there is a need to try to understand which are the best biosimilars. So it may be possible that the best biosimilar is for adalimumab or for infliximab or for ustekinumab. I think that is important that you exchange these type of information to really understand what is the most convenient prescription for the patients. Thanks.
Thank you so much, Lorenzo. Can I go back to Patrick again? What do you think are the capacity issues in terms of thinking about the ecosystem, building an ecosystem of care for multimorbidity? What are the innovations and the reforms that we need, or probably capacity issues that we probably need to put at the forefront going forward?
Thank you very much, Yemi. So, interesting question, but I think it's also a very complex question, and I can speak to the perspective of guidance in this space, the aspects on uh, capacity in guidance development as well, and guidance use. I think it's a different ball game to think about capacity in terms of clinical practice, hands-on for doctors and nurses, and integrating departments in work. I think that's a different ball game. But I could touch briefly on that. So first, talking about the guidance in the space and the capacity. So we are currently running a scoping review for the health decision making in Africa to try to understand how that landscape looks like. What do people in that context consider as health decision making guidance? How can this be integrated, and what is the capacity that exists on the continent? And I must say that we have preliminary results, and it clearly demonstrates that there is some capacity on the continent, but it's very limited. And most of those who have pushed forward this guidance for health decision making have been the WHO, and then some civil society organizations in some specific areas. They have mostly pushed forward, supported governments and clinicians in the region to be able to have access to resources, including capacity building for guidance. Now, there is a lot that needs to be done. I mean, within the African context, how can we support governments to be able to, let's say, if the government of Cameroon wants to have a specific guidance for multimorbidity, and they do not have the resources in place, how do they go about it? If they need to build capacity and they do have the resources, how do they go about it? So these are things that we need to be thinking about in the space of guidance. Now, in the space of other areas where it's very important that we are able to do something, is how can we ensure that a GP who is managing a case with multimorbidity is also collaborating with a physiotherapist, which I think in Cameroon, for example, most health districts now have rehabilitation assistants or physiotherapists that they can use in settings like this. But how can they work together? How can they collaborate with another GP who maybe has a better experience in another space? And this is why I said that this space is quite complex, because it might require resources and investments from the government. But I think that the role that we can play in this space is to try to highlight the importance of this, and then see if we can use this for advocacy as well at government level, at practice level. Thank you, and over.
Oh, thanks, Patrick. I just want to pick up on what you said and what Kitty's mentioned about leaving evidence and not trying to solve a problem of the past. And I was just thinking that would it be helpful, because a lot of the documents and evidence, the thing is, we don't even have a lot of evidence about multimorbidity in Africa. That's the truth. But going forward, I know with webinars like this and other initiatives, massive things that WHO is doing and other organizations, there will be new evidence evolving. And one of the things that we can begin to think about is to develop a knowledge translation center, a knowledge translation, maybe vehicle to kind of make sure that those evidence is continually being updated, being contextualized, and there are signals going out every day from the trusted sources, that brings about all the evidence, about care, about person-centered, about the right EML, about the right quality of the medicines and the medications, the right type, to reduce polypharmacy and all of that, bring all of them together, develop some kind of signals that very, very simple that, healthcare professionals in the front line can use and quickly incorporate into their practice. But, that's just something that I was thinking about as both Patrick and Kittis were talking. I want also answer a very brilliant question or reflections from Lynn, then Connect. And I think this is really directed to Dr. Gonse. But before that, I was wondering if Karen would like to weigh in on some of the discussions that we've been having today, and then we go back to the question and allow Dr. Gonse to answer that.
Yeah, so I was actually looking through some of the notes that that I have from our previous discussion last time, and I think that some of the points that we've already discussed have been absolutely excellent. And I think that just to your previous point, Yemi, about really having a contextualized knowledge translation center, because there is not enough evidence for the continent about strategies that work for multimorbidity, and taking an innovative look, and instead of looking to the past, as was previously mentioned, like Kittis was saying, and all of some of the changes like that you had mentioned, Kittis, last time in our last discussion about how sometimes it's incorporating the interest holders from the very beginning, and how it's sometimes the small changes of font and presentation, and can really make a major impact, is really, really foundational. But I think that what seems to be the common thread through a lot of this is not only the complexity, like you had mentioned, Patrick, of the patients, and how for the individual clinical officers and clinical teams who are trying to manage this complexity. And then, for the individuals themselves who would have to be going back and forth to several specialists, which we know would create the further complexity. And then the polypharmacy that you've talked about, in both presentations, Lorenzo, is I know that it's and then the challenges around what you had mentioned about when we're thinking about overall trying to figure out through shortages and counterfeit meds and trying to how do we be mindful with resource limitations that we experience and what those models would look like through these kinds of innovative solutions, which I think, you know, as you were saying, Patrick, we've seen that we have some of the capacity there, and I think it's starting to work, and it sounds like, you know, as previously mentioned in one of the you know, questions from one of the attendees, it sounds like the interest is there too. I think it's just time to capitalize on some of that. So I think some of my questions are is how do we best coordinate these efforts in from our various perspectives? And there's already a lot of work in this realm that's going on. How do we make sure that we align all of our efforts here? And with a lot of challenges in this current context that we have, where's where's the best way to mobilize these efforts so that we have these innovative, you know, solutions where we're able to test these small little pilots of models and implementation and use that implementation science and collaborative to make this work? How do we spark? Like, what are your thoughts on that side of things?
Yeah.
Any initial?
I think that what the questions that you've just asked and the question on the chat box from Lynn, I think Dr. Gonse will be the best person to probably shed some light on that. Do you want to take over?
Okay. I think in terms of integration, especially for HIV and NCDs, different countries are at different stages of implementation. So even Uganda that I used as an example, they are also at different stages of implementation. There are some health facilities where, for instance, they will have the same clinician seeing HIV, mental health, or NCD, diabetes, for example, but booking different days. But then there are other settings, other clinics, still same in Uganda, where they have a chronic care clinic. So if there are consultation rooms, say maybe it's a district hospitals, they have four consultation rooms. Each patient can go anywhere in that consultation room. If I have diabetes and I also have HIV, I'll be seen in that one consultation room. But we know that before, you'll be attended for hypertension and we are told maybe come back next week or go to the other room for another condition. So I think what Uganda did, they trained them, like post training. They trained all of them in the management of HIV, NCDs, unlike other countries where if it's for HIV, they'll just train the people who are manning the HIV clinics or infectious disease clinics. They'll just train those ones in HIV management. And then those that are manning NCDs, they'll be trained in NCDs. But for them, they train them in everything, mental illness, your normal NCDs or diabetes, hypertension, and then as well as your HIV. So I think that is what makes them stand out. So which means a clinician in one room can manage each and every patient that comes in instead of sending them elsewhere. And then also even for pharmacy, they have like a shared pharmacy points. Other countries, pharmacy for HIV is not the same as the pharmacy for other conditions. So, but for Uganda, even the pharmacy is shared. You come from, whether you have one condition or 3 or 4, you just go to the same pharmacy. And then even the way they do the waiting area, like their waiting area is just one waiting area where they do health education across board. Instead of, if you separate, you are just going to be doing your health education, focusing on your specific area of interest. So, but obviously the complex cases are referred to specialists, and specialists, they are in referral hospitals, but the district hospitals mainly are manned by your normal GPs and your clinical officers, depending on the setting. So I think that's what they are doing. They are trying to, you see the model where you have today, Monday, you have mental health, and then Tuesday you have diabetes, and then Wednesday you have hypertension, then Thursday you have HIV, still doesn't work. So that is what they're trying to run away from, so that they just have one day for all chronic conditions. So that if Honzi here has diabetes, hypertension, and also is HIV positive, Honzi can go and be attended on that particular day. So that is what Uganda is doing. Thank you.
So thank you so much for that. Dr. Gonse, I know you mentioned in some of the other programs, because I know staffing in general from a healthcare system is challenging, and it sounds like that's quite a bit from a training perspective. Does that program also utilize some of the task shifting approaches as well as some of the other programs that you discussed earlier?
Yes, actually, most of these countries that I think those that are doing better than others in terms of integration, they're actually doing task shifting. There are countries that have actually trained even nurses to dispense ARVs. Because when you look at their, for example, the essential medicines list in terms of the prescription rights, you see that maybe nurses are not even covered to prescribe certain medications. But because of the task shifting and task sharing, they advocate for that, like, let's train these nurses so that they can dispense HIV medication, or they can even dispense hypertension medication. So task shifting is the key for most of these countries that are integrating their services. And then I think there was a question about, I think from Nigeria, about integration. There are quite a lot of countries that are actually doing integration of HIV, NCDs and HIV, especially particularly hypertension. There are quite a number of them, and some of them have even published. Some of them are even now expanding to do the cost-effective, So I think I send my email, we can engage on the side and see how we can assist in that aspect, or even link you with those other countries so that you can learn from them.
Yeah.
Thank you, Olga.
Thank you, Dr. Nis. I'm not going to put you on the spot, but I just made a note of something. Currently, I know WHO, especially WHO Afro, they're using the word NCDs, integration and all of that, but they're not quite on the word multimorbidity, which is a thing. But I'm not going to put you on the spot. But I thought we need to go away and think about it, because just thinking about NCDs alone, and even NCDs integration, it still does not tell us that multimorbidity is of a key focus and a key driver. But we know from data, from the people that are on the front line, that what people are saying more and more is multimorbidity. And of course, a lot of them are NCDs, multimorbidity, but including infectious disease. But that's something else that we need to think about. And I've got really brilliant suggestion in the chat box also about what WAFERs as an applied health research institute can do within that space, focusing on Africa, evidence-based of what works and in what context. And I think we have started a little bit about this. I don't know if Miriam wants to talk a little bit about the things that we're doing and the approach going forward, just in 1 minute, because we're running up to the time where we have to wrap up. Okay, that's fine. I'm gonna stand in. I know a little bit about that. So, for example, we've already conducted a scoping review of the different multimorbidity guidelines in low and middle income countries. We know what the answer is to that, and I think I shared a little bit about that. We've then gone on to talk with stakeholders. We've done surveys and interviews, and also done stakeholder workshop to just kind of look at what could the ecosystem of multimorbidity care look like for a typical African country. So these are just the foundation. And then we're now looking into the epidemiology in itself, because we need to understand the data. Like we've been talking about NCDs. What are the NCDs? We know that HIV is being, well promoted. We have diabetes and hypertension, which are the cardinal things. But there's quite a lot of other things that are probably not actually had that attention. And that was why I said I don't want to put you on the spot to make you to answer, but the issue is that it's multimorbidity. We did a health outreach recently, and it's just really to make people to be aware about basic life support and stuff like that. And at some point, there were two cases. We also did another outreach, I think it was 2 years ago, on osteoarthritis and joint pain. And you wouldn't believe it, even though those workshops, they were focused on those particular diseases, then people, all the participants in that, they wanted to know about 10 other things, and all of them are multiple long-term conditions that they were living with. And that's one of the reasons why I said, when Dr. Bartholomew was talking, we need to be thinking about patient-facing evidence products as well. And yeah, so that's just the basics. And obviously, we do have a solid ground from some of the approaches that you shared today that we can build on and try to implement those things, research them, and try to see what works and in what context, and with little resources, and make sure that this is all contextualized. Dr. Gonsi, I see you're very keen to to respond to this, and then we'll go on.
No, I think I just wanted to comment, because as we were speaking, I was, NCDs, like you were saying, NCDs, there's just, even the definition of NCD is so broad. But because most of the countries don't have the capacities, so I think that is why now countries end up prioritizing. Because when we look at the 4 major NCDs, there are the ones that I think they have the highest burden and also with the greatest gaps. So I think the idea is, if we can facilitate effective implementation of their best by interventions, then you'll be able to address other NCDs. But all the NCDs are equally important. But I think it's because of the capacities, what countries can do. Like you see, for other countries, we realize that they even have sickle cell in addition to the 4 major NCDs, or have sickle cell. Other countries, in addition to the 4 major NCDs, will have kidney diseases and all that. So for me, I think it's because of the resources, the limited resources. And I think you are right also when you say in terms of multimorbidity, Afro, feel free to reach out, because I think in that space there's a lot of gaps, like you are saying. There's no country that has guidelines, and usually the guidelines the WHO has to guide as well. So I think feel free to reach out. But I think also this is a start. NCDs didn't have there's no funding when it comes to NCDs. But we are hopeful that with all these UN high-level meetings, though most of the time implementation is a challenge, we do agree to these things, but in terms of commitment, that's where the problem is. But I believe with time, things will get better, because from HIV, we can see that the investment that we did for HIV, to me, I always say that investment was not a smart investment. They've saved Honzi from dying of HIV. Now Honzi is sick from complications of hypertension, complications of diabetes. So it didn't really, it helped, yes, but I think we can do better. Thank you.
Absolutely. I can see Karen really smiling and happy when you were talking. And yes, that's one of the things that we want to do as Gene Multimorbidity Working Group to see how we can develop guidelines for multimorbidity. And one of the things you mentioned, so we will be reaching out. If WHO would want to drive this together with us, incorporate the EML, incorporate the WHO design principles as kiddies, as starters. Those are the places where we need to be shaping, the direction of travel for multimorbidity care. But you also talked about prioritization. Even though I agree that resources are limited and people need to prioritize, but I think instead of prioritization can happen on individual clinician to patient level. I don't think prioritization should be happening at country level because if we prioritize some of these diseases over another and we don't really think of them as, holistic, what will happen is that if somebody picks up 2 or 3 of the things that, that are wrong with a particular patient A, but they have other 2 or 3 other things that have probably not been prioritized, then chronic care clinics model and WHO PEN Plus, those models, they would fail because what happens is that the patient sees that only 2 is prioritized and addressed. Then they will go out, they will do self-medication, they will go out and see other healthcare professionals, they will buy things from off the counter, and then they will be back with more complications. So, and we go on in that cycle, is a vicious cycle. But I think what would maybe help us if we try to develop a clinical guideline, a framework by which clinicians can sit down with patients and prioritize what is the person-centered, what is the key thing that needs to be solved for you. And they have that single one consultation. Look at the EML, look at what is best for that patient at that particular time and say, well, for you, these are your concerns. This is what you need. This is what, let's take it one step at a time. Let's do this. And then we take care of the other things as they go. But the patient, they will feel prioritized. That would increase the trust and they wouldn't go out and do all the self-medication and, will get into all of those muddled waters which has plagued healthcare. And if we continue in this trajectory, what will happen is that we're still creating more burden for the already overburdened healthcare system that we have because more people will keep on showing up in hospitals for the side effects of polypharmacy and self-medication and all of that. So things will spiral out of hand. So I think, yes, we would work together and see what we can do and develop clinical guidelines, but they will be person-centered and we would look at how it can be lay enough and also help the public to also understand what should be standard care, what should be evidence-based care for multimorbidity. Because if the patients understand, they can also go away and think with the consultation, with the support of the clinician and, go away and make use of those information to support their own self-care and self-management. Ultimately, I think the discussion should not stop here. And I really want to thank everyone for the times that we've had together, and thank you for all the panelists and the keynote speakers. Thank you, Lorenzo. You put in so much hard work speaking one webinar after the other. But yes, discussion should not stop here. We would regroup and see what we can do going forward. We will bring up all these new initiatives. And if any of the participants, if you have anything good stuff that you're doing, please showcase and let us know, because the idea that, like Patrick said, is to learn from one another, make sure that we bring all of these initiatives together, learn and improve and continue to improve. I think it's a PDSA cycle. We plan, we do, we study, and then we act again. So it needs to go on. And thank you so very much. And also for your time and attention this afternoon. Been a pleasant discussion. Thank you.
Thanks, everyone.
Yeah.
Thanks, everyone.
Thank you, everyone. And
Thank you.
bye-bye.
Bye.
Bye.
Thanks and bye-bye, everyone.
Thank you, Patrick. Thank you.